Hello and welcome to Sensei podcast. This is Manos Brilakis discussing with leaders in the field of CTO and complex PCI. Sensei means teacher or master in Japanese. The goal of the Sensei podcast is to help you learn and improve in CTO and complex PCI so that you can become the best that you can be and offer your patients the best possible results. Hello, everyone, and welcome to Sensei Podcast. It is my great pleasure to introduce our guest today, who is Dr. Göran Olivecrona from Lund, Sweden, one of the most senior CTO and complex operators in Europe and around the world, with whom we worked for a long, long time. So, Göran, welcome again. Thanks for being part of the Sensei Podcast.
It's my pleasure to be here. Thank you so much for inviting me, man. It's always great to see you and talk to you now that we've started to get the world more organized after the pandemic.
Yeah, absolutely. Although still the remote skills, I guess, still come in handy from time to time.
Yeah, quite so.
So, Göran, tell me a little bit. I know you've been doing this again forever, and you were one of the first people to tackle these complex lesions at the time where things were not quite as well defined as today. So how did that happen for you? What made you get into this area and make it your focus of your career?
Do you mean like from the CTO complex stuff or into cardiology as a whole?
I mean, both, actually.
So my idea basically was that I wanted to study medicine and become a doctor. And I think I was from an early age sort of driven to something where you work with your hands. So it was mainly surgery that was the driving force. And I didn't discover really, I was completely set on a surgical career. And during medical school, we can usually start working after you've done over 4 years as your junior assistant doctor for short temporary works during summers. So I did this in thoracic surgery, and then later on, I thought it was kind of boring because it's pretty scheduled, everything. You can sit and drink coffee outside while they have to put the patients under anesthesia. So, and I wanted to be like in the middle of things when it was happening. So I was driven more to trauma surgery. And then after medical school, I went up northern Sweden and worked in a hospital and got to do a lot of, basic junior doctor surgery work, appendectomies and nailing hips that have been broken, that type of thing. And it wasn't until I did my internship that I also discovered that the general surgery was, also kind of boring, and there was no trauma in Sweden. So a lot of abdominal pains, observation overnight and so on. So during my internships, which is mandatory in Sweden, where you do 6 months in surgery, 6 months in medicine, I did have a lot of interesting patients that came in and went into cardiac arrest, and you had to defibrillate them, and often they would be sent off to Lund University Hospital. This was a smaller hospital on the outside. And although I was set on my career as a surgeon, somehow the thing was that I wanted to see what happened to those cardiac patients because they were really interesting, and they disappeared to Lund. So I had an offer to go into surgery at Lund University Hospital after my internship for residency, and at the same time I wanted to have do a 6-month temporary work in cardiology department. And my professor here, Bertil Olsson, he then got me appointed, to entry to cardiology, junior doctor, and this was in 1994. And in the middle of the summer, a patient comes in cardiogenic shock and ends up doing the first primary PCI patient that we did. And he was put on a balloon pump, and they opened the LAD. And he actually had 3-vessel disease, and then he, ended up going to surgery a couple of days later with a fantastic result. But basically, cardiogenic shock, anterior wall infarct, first primary PCI that had been done in our hospital in '94. And this really opened up my eyes that, and as the months progressed, I realized that the surgery department wanted to have an answer. Did I want to join them or not? And this thing that's finally set me on my course was that the professor asked me to be the first cardiologist to train in interventional cardiology in the hospital, because it was completely owned by radiologists. So it was the radiologists that controlled the cath labs, and they did not want any cardiologists there. So I then ended up doing angiography training and decided not to go for surgery. And I was in the beginning of my residency. So this was only 4 months or 5 months in that the professor asked me, and I started 7 or 8 months afterwards and doing training in angiography. And a couple of months after that, I was sent to Gothenburg to do 3 months of PCI training. So I did 100 PCIs, basically a year and a half after I left my internship, before I'd really gotten started into my residency.
That's front-loaded.
And I was kind of unpopular among the radiologists. They would have much more preferred, I think, a cardiologist who had a thumb in the middle of his hand. And I was essentially used as a ram to break the doorway into the radiologist-controlled territory. And then I could help my other colleagues from the cardiology department. And then the interest sort of died also among the radiologists, even though we still have one fantastic colleague who is a radiologist who works with us. But junior radiologists are not so interested today in going into interventions. And that sort of set me on the road. And in 1996, when I was in Gothenburg, that's when I really enjoyed CTOs. So this is going to sound crazy, but this is when the hydrophilic wires came, and we could do CTOs. And with microcatheter, the ultrafuse microcatheter was used, and this was the really challenging part that I really enjoyed. But unfortunately, as you know from the SICO trials and early trials like that, the problem was that they all came back, almost all of them, with restenosis or reocclusion, and interest sort of died in the Western world, at least, of performing CTOs. But it still remained on my horizon as that the challenging cases, which I enjoy.
And how did you do CTOs back then, right? You minimal equipment, no retrograde. How that must have been quite an adventure opening a CTO back those days.
I mean, we didn't do the long procedures. I mean, the number of wires was very limited. You had the ACS wires, the earlier form of BMW wires, and you could use the stiffer parts. But you also had some Boston wires that came out that were hydrophilic, which were really nice to use. And of course, I mean, you look upon the cases that we do today, this is nothing. I mean, these were cases where you had, short chronic occlusions, and wouldn't be a challenge today, I think. But back then, it was a challenge, and it was also using over-the-wire balloons. But we did use the microcatheters, a small microcatheter, ultrafuse. I don't know if it's around anymore. And this was then as a means to change wires, change the bend of the wires among the very small number of wires that we had to pick from.
And then how did it evolve? Later on, obviously, CTO techniques improve, equipment improve. How did you get back into that swing of things?
So I think the really major shift, although it was a little bit on my horizon, and every once in a while it could be used in patients that were turned down for surgery, or there were no other alternatives. I think that the thing that happened was the drug-eluting stents. It was, it changed everything, because all of a sudden, there was interest in the drug-eluting stents, and then trying to understand how, much could you improve the reocclusion restenosis rates in the CTOs, and it was, useful to actually perform CTOs and rather small numbers of restenosis or reocclusions. And then it restarted, and I think that was the time also that we all of a sudden realized that the Japanese had been moving along and continued to improve wires. And as you know, Asahi, as it's called with the pronunciation, steel company, and how they were, started producing these wires. I think as a spin-off thing. Their major thing was the steel production, like U.S. Steel.
Mhm. And then, but how did you actually learn to the procedure? So again, now you have the miracles, you do have some better wires,
Yeah.
but still, it's challenging procedures and a lot of technique and equipment. So was that learned just by experience? Did you go to any other labs? How did you learn?
So I think, the first thing was that we knew that there were some pretty stiff wires, like the Miracle 3 wire and the Miracle 12 wire. Although the Miracle 12 wires was something that, it was a completely different wire than anything that we had used before. Only used with much, much caution. And then we're talking 2004, 5, and then I think in 2006 is the first time I had the pleasure of meeting some of the Japanese colleagues who came to our institution. One of the medtech companies sponsored him over here, and we thought we'd just see what he could do with some really difficult cases, and it just blew my mind. We'd heard about the retrogrades. I hadn't seen it. And then Itsuo came to our institution and helped us with a couple of cases that I would have considered, absolutely insane. And then we actually organized a meeting, I think it was in 2007 in my hospital, where we brought in my colleagues from Sweden or from Scandinavia to just watch Tsushikane do some cases. And I think, people were interested in this, but they thought it was, kind of crazy. And Atsuo came and he did 3 cases, I think, in 2 days for a live audience that was in my hospital. And it blew away the people that were there. And some of the most senior PCI people in Sweden who they were, I remember one guy commenting that after the procedures, he just stood up and said, "These are the best PCI cases I have ever seen." And I think there were not so many of these cases shown in PCR and TCT as it is today. Like you said, you had to sort of go visit them or have them come to you. And this is what we did then for a number of years. And of course, we progressed very quickly, adopted the wires as they became available. And the problem was that every time one of the Japanese colleagues would come to us, they would always have something new. First thing I remember was the Fielder FC wire, and only available in Japan. And next year it was Fielder XT. Then it was the Corsair catheters. And it was like they always had some kind of miracle equipment stacked away in their bag, and you sort of had to look at it and realize that you couldn't get your hands on it. We were still stuck with the over-the-wire balloons to do the crossings. The Corsair was not available yet. And you just wish that you could, could you drop off a few of them and leave them in our hospital? And and then I think that it was a game changer also to meet Bill Lombardi, because we were struggling with the we did a little bit of retrogrades, but simpler stuff, and it was the reverse cart that I think was a crucial part. Stingray was coming along and Crossboss and so on, but really the basic sort of reverse cart type of procedure. And I think that I met Bill Lombardi in 2010, and I think in Italy somewhere. And it was one of the earliest EuroCTO club meetings. And he was just telling me, "Oh, you just do a reverse cart, you knuckle up and knuckle down, and then you take a big balloon and you go antegrade and you just wire it." And then we made a deal that I would go and lecture on some of the cardiac arrest stuff that I had been doing in Bill's hospital, and he would come to Lund and show me how to do the reverse carts. And that was a real game changer for me, I think, also.
Perfect. So you met with some of the best people from Japan, from US, so that really helped. And you mentioned about the cardiac arrest as well, which I know you've done a lot of work, and the Lucas and the other devices. How did that work? Was it in parallel? Was it separate? Was it part of the whole process of complex? And how did you get an interest in that and be able to advance the procedures there and the devices?
Well, the Lucas device, which is manual or mechanical chest compression, this is a cardiac arrest cases, which back then the tables didn't really tolerate too much chest compressions in the cath lab. So the basic idea was that if somebody went into cardiac arrest, then you had to pull back the table and compress it so that it wouldn't break the cath lab table. And then you for a few seconds, you move the table up to where you have your II, and then you would do, very briefly injections or the work that you wanted to do. And then you had to pull the table back down again and then do compressions, and it worked like that. My next door neighbor is a cardiac surgery professor, and he has been developing ways of preserving lungs mainly. And to do this, he needed to circulate his solution, and circulate the solution you would inject patients with this who were, essentially dead. When you gave up on a cardiac arrest patient, then you would put the Lucas device on. You would inject his solution, and after 20 minutes you could stop. And then after that, the lungs are preserved for 24 hours. So you could have a calm discussion with the family, and that's what we did. Then was that we had in our hospital, we were trying to recruit patients, and they had an emergency room. And one night I was waiting for a patient in cardiogenic shock coming to the cath lab, and this was in January 2004. I knew they arrived in the hospital, but they seemed to be stuck in the ER. And then we sort of called down, and we found out she was in cardiac arrest. So we were sitting up in the cath lab waiting to see what was going to happen. And usually, that's where the story ends for most of these patients, or many of these patients. But all of a sudden, you could hear this thumping, thump, 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 thump outside in the hallway outside the cath lab. And they were coming up with this, Lucas contraption sitting on top of the patient. And they said that she was in cardiac arrest. And then I looked on the vital signs, and the patient had a blood pressure of something like 85, 90. Oxygen saturation was 90%. And I thought that you had to be, she's not really dead. And then we stopped the Lucas, and there was no blood pressure. And then we started the Lucas, and there was blood pressure. And then I thought, I have to look at this in the cath lab and see what it looks like. So we brought the patient in, put her on the cath lab table, and injected contrast in the coronaries. And there was, I would say, TIMI 2-3 flow in the coronaries, except the one that was infarcted. We opened it up and did PCI with the ongoing Lucas. You didn't have to pull the table back up, down, or up again. And the patient ended up not surviving. I mean, she had pretty severe coronary disease, and it was early. But I mean, if you could create this great blood flow with a mechanical chest compression device, then this could be a tool for patient to crash in the cath lab. We quickly discovered, after bringing up lots of patients that were essentially dead from the ER, that the main use was for patients that crash in the cath lab. And then we had a number of patients that they crashed in the cath lab. Normally, our subjective opinion was that they would have had difficulty to survive without us being able to sort of uninterrupted continue the procedure with the onboard chest compressions. And this was a time when ECMO was not so readily available. So this was a good option for us.
So it was serendipity, I guess, having the option, starting using it and seeing good results, and then expanding its use. And again, I mean, I can tell you it has saved many people. I mean, in our cath labs here as well, that remains the go-to device for cardiac arrest in the cath lab and in the emergency room as well. So, Goran, what did you find most difficult in learning through all these years? Was it the techniques? Was it the mindset? Managing the equipment? What do you find the hardest thing to learn in doing complex and CTO interventions?
Everything? No. I mean, it's patient by patient. I think I think one of the crucial things that I found really difficult, two things that I had to sort of overcome my own fears to do. I think what was to really do the reverse cards in the beginning, and also to I think we're starting to do the ADRs that it was not so dangerous as you think. You would think you have the stingray balloon or in the beginning at least, and overcome that it's and that's a mindset that I think that you have to get used to. But in order to get that mindset, you have to be also have some experience before. So I mean, those were I think the main things. I think also tackling really difficult coronary disease, like in last remaining vessels, where you have to go and use Impella, where you know that if I lose this, it's game over, because we can't leave this patient if they've been turned down for surgery. We put an Impella, we're keeping them alive with an Impella, patient's awake, and you're working on the last possible vessel, and if that goes down during the procedure, you're essentially going to have to tell the patient we're going to turn off the Impella at some point.
Okay. Now, when you do these cases, the complex cases, the high-risk cases, do you get stressed? Do you get anxious?
Yes, of course. But I sort of thrive on that anxiety and nervousness, and I like to feel nervous every time I go into any patient, because if I feel a little bit at least nervous, then I think I do a better job, and I try never ever to underestimate even the simplest case, because you never know what's going to happen. 10 seconds or 2 minutes later, you could be standing in a room filled with anesthesiologists and cardiologists, and trying to figure out if you're going to go on ECMO or Impella, or how you're going to solve it. So I think I thrive on being nervous, but I think it does not get in my way. It may actually hone my skills to be even more attentive. So it's useful.
And then how do you deal with the cases that don't go well, that fail or have a complication? Do those bother you? Do you get over them? How do you deal with that?
I think the major thing is I have a great group of colleagues that I work with. We're very, very open. If anybody has a complication, the first thing we do, especially the next day or the same day, is to explain to our colleagues what happened and see what they would have done. Could there have been a better way to do it? You talk it through with this group of great friends and colleagues. And that's, I think, my therapy for handling these situations. Your colleagues and the support that you have from them. And also, I think we have pretty thorough, prior investigations of the patients. We test them for viability or ischemia testing, so you don't feel that it was something stupid that you did, that you might not, it was unnecessary. So when they are in our cath lab, I think it should be clear that they really should be there. They are in the right place, and that you try to do your absolutely best. And if you feel that you've done your absolute best, then it's less painful, even though I do, of course, remember my patients that do not do well, and I still think, of many patients, not that many, but some of the patients today, even though it happened years ago, could have done something different. If there's new equipment that becomes available, I wonder what would have happened if I had the equipment back then.
Yeah, absolutely. And then, are there any specific things that you look for in the many people you trained and you're training? Are there some characteristics that make you think that this person is going to do well and he's designed to do this complex or high risk procedures?
I I think that it's an interesting point that you raise. It's I think you get a sort of the whole picture available uh, while you are seeing the person develop on many different levels. And it's a challenge to find these people, I think, because I think it's easier if you are in surgery, in cardiac thoracic surgery, for example. They know pretty much well that they have the hand skills, because otherwise they wouldn't go into surgery. I think they also have a little bit of personality trait that it's surgery, that it's you're going to have complications and so on. But many patients, that people that go into cardiology, they may not at the outset know that they're going to go into something where they're going to be doing a craft, basically. So then some of them decide that they want to go to interventions, but you know you have to have good hand skills. You also have to have good judgment. You also have to be able to handle stress. Uh, and you also have to realize that you're going to be essentially working as a junior doctor on call until the day you retire. And if you find that you fit in all those categories, then I think that you're going to become a good interventionalist. And on top of that is where you're getting at is, how do we see that they have all the traits, they're good with their hands, but there is a different tier system there. Some are good, some are really good, and a few are just brilliant. Um, and you have to put that all together. And the main thing, I think, is with the people that you train, the goal should be that they should not be as good as you are, but they should become better.
And then, are there any things you find very hard to teach, the hardest thing to teach to them? Is it the movements, the thinking? What is the hardest thing to teach them?
Um, there's one thing I don't think you can teach them, and that's good judgment. I mean, if they don't have good judgment, doesn't matter how skillful they are in all other respects. That you can't teach. The other things I think we can teach, and the difficult part there is, how much do you allow somebody in training to do wiring, for example, where you really have an only option. I mean, there's really one only available collateral, for example. Um, I don't know how you do it, but it's, when should you allow them to progress and do this and take over, but it's better for them to do it themselves and learn. I think we also sometimes have to allow them to fail, even they go beyond the sort of the last remaining sort of viable collateral. It's a one-shot thing. um, they also need to be able to fail, even though we won't be successful afterwards, which we might know. And I think that's also something that's part of the training.
Now, Goran, how do you keep fit to do all this work?
Well, I used to play. I play paddle ball. I don't know if you know this sport. It's a
It's like pickleball.
it's similar to pickleball, but it's much more running.
Okay, okay.
And it's a bigger court, and it's with a tennis ball and small paddle rackets, and you can use some of the walls. So it's a mixture of tennis and squash a little bit. And I also play squash, and I run, even though I sin and should do it more often. But I really do love running, and the lightness that you get the next day after been running 5 or 6 miles.
Perfect. And then do you do anything to keep you calm? Do you do any meditation, readings, any specific thing that calms you down, gives you rejuvenation?
I read a lot. I like to go to sleep and listen either to podcasts, usually somebody who speaks in a very slow voice, which sort of puts you in the right mindset. But I do want to learn meditation, yoga. I have some friends that do that, and that's my sort of next step that I want to learn.
Perfect. And then, do you have any favorite book or any favorite movies that appeal to you?
I read a lot of different things. I think that I like also to read because it tires me out. Basic biographies, autobiographies. Last one I completed was Winston Churchill, which was a pretty heavy book, but interesting to read about historical events and people. A fascinating person, Winston Churchill, for example. Movies, I couldn't say right off the bat. Which movie do you like, Manos?
Well, I do have multiple. I would say probably one of the ones that I found the most inspiration is Rocky. Someone who transforms himself into something bigger than what he used. So that's the one that comes to mind first. But yes, it's it's fascinating. I think in the podcast in general, the number one movie has been Godfather for interventionalists. So I don't know.
I would say that it's an interesting trait, but if you look upon myself and my wife, she's a teacher. She really knows her culture and humanities, and she likes to see the heavier stuff, where you get more catharsis. I think that you can test this among the people in podcasts. I get so much catharsis at work that so when I want to watch something or it needs to be very simple, like you said, the good versus the bad, the Rocky and that type of thing, where catharsis is for something else, is for some other people who may not have as stressful jobs as we do.
Yeah, no, absolutely. You're right. You do want to distress and relax a little bit more after all this. What are the things that you are most proud of? You've done so many things in multiple areas, but both personally and professionally. What are the things you are most proud of?
I'm immensely proud of how spread throughout the world Lucas became, and it's absolutely fantastic to see people that see it in live presentations and things like that, where I knew that I was there in a minute, and I was trying for many years to tell people that this is something you can use. In the beginning, it was just sort of standalone. Then, as ECMOs become more available, then it's an easy way to put the patient on Lucas first, and then you can calmly put the ECMO in, for example. But I'm also proud of the CTOs in Scandinavia, because there was a lot of skepticism about CTOs. Are they cowboys? Are they successful? Can they, they claim they can, get upwards of 90% success rates. And so I decided to, show them. And basically in 2011, I invited a couple of fantastic colleagues, Aaron Grantham, Bill Lombardi, Fredrik Galassi, and George Sianos, and invited my colleagues in Sweden to send patients that they considered impossible, but they wanted to open up CTOs. Many of these patients had multiple attempts to open CTOs, and they sent patients then from all over Sweden, and the operator who was from the referring hospital got to sort of dress up or scrub in with one of us from Lund, or Freddie, or Aaron, or Bill. And so we had 18 patients in 3 days, and we were successful in 17 out of 18. And the only reason we weren't successful in the 18th patient was that the patient got an allergic reaction before we had even started. And we actually were successful treating her some weeks later. So this opened up the door to, it was an aha experience for the colleagues in Scandinavia. And I think most people went back home and wanted to, figure out how to start the CTO programs if they were in larger hospitals. If they were smaller hospitals, they at least decided that it was useful to send their patients to the larger centers where they did have a CTO program. And I think this was a big game changer.
Yeah, no, you've done amazing work, spreading the the teaching and the people understanding how to do it and when it should be done. So congratulations on doing all that. In terms of now, though, what excites you the most at this time?
It's right now, it's the complex patient that I have to do tomorrow, who has an occluded right coronary artery, chronic, came in yesterday evening and had a 90% left main. And the surgeons, essentially, I would think that it would be good surgical candidates, but we have excellent surgeons here in our hospital, and there were some comorbidities that they decided to turn the patient down. And so we're going to deal with it. And right now the patient is on nitro and CPAP, and as soon as you take the CPAP off, he goes into pulmonary edema and gets chest pains. So, and you don't want to do this in the evening, and therefore we're planning on for tomorrow.
Well, good luck. That sounds like Lucas hopefully won't be needed, but it's good to have it standby just in case.
But I'll give you the other option to tell you also that he has bilateral significant subclavian stenosis. He's amputated, and he's got severe stenosis in his iliac. So there's no way we can put him on an Impella or an ECMO or anything like that, and his ejection fraction is 25%.
Well, I'm glad I'm not there tomorrow, but sounds like a challenge.
Yeah.
Sounds like a challenge. How about the future? What are you looking forward down the line?
So I turned 60 8 months ago, and I think what I'm really...
Congratulations.
Thank you, Manos. And congratulations to your program here also. I think that this is the point in life where it becomes really essential to really train. I have 5, 7, 8 years left working in interventions, I think, if I'm lucky. And in that time, I really need to just train the younger colleagues, because after that, I'm going to be out. And you have to retire, and mandatory retire somewhere when you're 68, 69 in Sweden. So it's my hope that I will train as many as possible to the highest possible level when I'm still here.
Wonderful. And then if you had to summarize from everything you've done about what is the best advice for people who are starting their fellows or early career, they want to become excellent complex interventionalists, what would your advice be?
My advice today, I think it's fantastic being able to see so many recordings that are available online. And this you can do at your own time, not in the least all your fantastic YouTube clips that you've put up, Manos. It's the fellows here in the Cath Lab or they love the stuff that you do. Really fantastic. I think it's also communication with your younger colleagues. Share and learn from each other. And also, unfortunately, but it's the way, is that you're going to have to put in, lots of hours in a rather short time. And I think that the more you put in your first 5 years as an interventional cardiologist, it's going to pay off later on. And I think you really need to, you train for 2 years in the US, I think, or is it 1 year?
It's 1 year of intervention, second year, if you do complex or you do structural, peripheral, second year.
So
otherwise it's one.
Basically there you're just going to have to, first of all, try to be in a hospital that has a serious volume. Volume is a problem in many places. But, try to get into a hospital which has a large volume, and, dedicate yourself during that 1 or 2 years. Basically eat, sleep, and just dream about PCI and complex procedures. And that would be my recommendation, I think. I don't know if you have any other recommendations, but the start, I think, is important to really do as many cases. And there's really no substitute for volume.
Yeah, absolutely. I mean, you cannot learn something unless you do it again and again. And as you said, if you do 100 PCIs in a year, I mean, that's a problem.
Yeah.
Especially early in your career. So I could not agree more.
Yeah. But ideally, I would say, in an ideal setting, you would do something like 500 PCIs on your own during your first year.
Absolutely. And then you have the skills and you're able to tackle more and more complex cases.
Yeah.
Again, unfortunately, the US, it's a little more challenging. The volumes are down and not everyone gets these numbers, but I completely agree with you that that's the optimal way to get good at something.
Yeah.
So, Göran, thank you so much. That was a phenomenal, overview. I mean, you've done so many things. Again, combining the Lucas, you created an amazing device that we still use quite frequently and has literally saved many, many lives. A lot of teaching and progress on the CTO world. So you've done phenomenal work and leaving a big legacy behind you. So thanks again for everything, and very excited to have you on the podcast again today.
Thank you very much, Manas, and thank you for all the fantastic stuff you have done for interventional cardiology and especially the complex and CTO world. Amazing stuff, Manas.
Thank you for listening to the Sensei podcast.